Good morning. Good morning, everyone. I think we're going to get started. I have to kind of lurch over because I'm so tall here. Happy Tuesday. I have the pleasure of introducing Dr. Mary Nakamura. She's a professor of medicine at UCSF and is one of the leaders in the field of osteoimmunology. Much of her work has been focused on the role of the innate immune system and the receptors on osteoclasts and immune regulation of bone metabolism. She has over 50 publications in this field. Her training path took her from coast to coast. She went to Swarthmore for college and Yale for medical school, went to the West Coast for internal medicine residency at UCSF, back to the East Coast to Johns Hopkins for rheumatology fellowship, and back to UCSF for further training in rheumatology and immunology, where she has been since that time. She wears many hats. She's served on the Scientific Advisory Committee for the RRF, and she's a regular member on the Skeletal Biology Development and Disease NIH Study Section. She's the co-director of the UCSF Stanford Arthritis Center of Excellence, associate director of the UCSF Premier Precision Medicine Rheumatology Center, which is a NIH-funded P30 center, and she's the head of mentoring at UCSF for our fellowship. Most recently, her work has shifted outside of the bone and joint and into the brain and heart, where she's studying the role of myeloid cells on tissue repair in these vital organs, which will be part of the focus of the work that she talks about today. Personally, she's been a role model to me on how to practice thoughtful rheumatology. She's the reason I know how to read x-rays, and she gives great guidance on how to balance life and the many demands of an academic career. So I want to thank Mary for coming this way to talk to us. And with no further ado, here she is.
Well, thank you so much for that kind introduction, Katie. It's really a pleasure to be here, and you know, exciting to get to see some of our former trainees really doing well in a whole new place. This is actually where my lab is at the San Francisco VA. We still have one of the nicest views in the country, and we still have our labs here, believe it or not. And so today I'm going to talk a little bit about myeloid cells and inflammatory arthritis, and what role I think, or we think we'd like to think about them playing. Just figure out how to work this. Okay, and so I don't have any disclosures. I actually have no research support from industry. So I wanted to talk about something that I thought would be relevant to both scientists and clinicians. And so I wanted to talk about sort of studies we've done in mouse models of rheumatoid arthritis. As you know, rheumatoid arthritis is really sort of a hallmark disease in rheumatology. And it's really a disease where you have both systemic inflammation and localized tissue damage and localized areas of concern. But we all know it has systemic manifestations and systemic complications as well due to the chronic inflammation. And so in a lot of ways, it really is a hallmark disease of chronic inflammation. And I've worked for a long time on aspects of the innate immune system, and when I started working on the innate immune system a long time ago, people said, well, why do you want to do that related to rheumatologic disease? Because these are T and B cell mediated diseases. And it is true that rheumatoid arthritis is very much a T and B cell mediated disease, but innate immunity has a significant role as well. And I think now that's not so unclear. But the way I just wanted to say how I like to think about innate immunity. So innate immunity is your body's, in a sense, rapid response system in a lot of ways. I used to say that they were like the sentries of the immune system, maybe because I spent my career at the VA. And they were sentries of the immune system. We're sort of looking out for abnormal, dangerous things and sort of really able to respond quickly and then call in more specialized troops, in a sense. But the other thing they're also important in not only recognizing sort of dangerous infections and other things is to really think about sort of maintaining homeostasis and promoting tissue repair. So I think that innate immune cells are really critical to promote tissue repair and homeostasis. And I think a number of investigators have more recently suggested that this is one of the problems with rheumatoid arthritis, that actually the mechanisms that sort of maintain homeostasis are one of the things that has gone awry. Okay, not used to using a PC. I go to All right, so and so in keeping with that, the innate immune cell I'm going to talk about today is really the macrophage. And macrophages really have been shown by many investigators in more recent years that they play a key role in the processes of really promoting tissue repair and helping to maintain homeostasis. And in addition to the idea that they generally do that function, they also are known to sort of adapt very closely to their microenvironment, and that they really tend to fulfill tissue-specific and niche-specific functions and really sort of adapt to their environment and maybe play slightly different roles at slightly different times for each specific niche. You think about what they do in tissue damage. Really what they are doing is a number of things. They are important in initiating inflammation, to remove tissue debris. They actually are important in phagocytizing and clearing out pathogens, dead cells, both necrotic cells and apoptotic cells. And in doing all of that, they sort of help initiate a tissue repair process. And actually, there's increasing information that suggests they're also important in helping to resolve that inflammatory process, both by producing an anti-inflammatory cytokines and also a number of sort of pro-resolving kind of molecules. And we really feel that myeloid cells and macrophages are major players in all of these processes. So this is a picture that I wish I had drawn, but actually it was in a recent publication by Georg Schett, who is one of the original osteoimmunologists, who really has done quite a lot in this area. And they recently in this review article talked about chronic inflammation as really being a problem not just of cellular activation and cells being activated in the wrong circumstance, but also cells being, the problem being resolution. And that the lack of resolution is equally big a problem as the excessive activation. So in thinking about this, that there is sort of on this side, this is activity and this is over time. There's some sort of stimulus that's leading to the onset of inflammation, and then the activation is promoted. And it is promoted by, both T cells, B cells, but also inflammatory macrophages, neutrophils, and other myeloid cells. I'm sorry about that. They also, then the inflammatory process will go on and become chronic. I guess I can't use that pointer the same way I thought to. Anyway, and then going up to the right-hand side is tissue damage occurring over time. Normally, the process will be resolved, and resident macrophages and a number of other regulatory cells, including lymphocytes and innate lymphocytes, both and regulatory T cells, and other innate cells, such as the eosinophils, are important in the resolution. And so at the branch point between going to tissue damage and going to resolution is sort of, in a sense, one of the points where a chronic inflammation can go awry. And that is a consequence of it can be a consequence of dysregulation of really any of these cell types. But one of the cell type I'm going to talk about a little bit is more the myeloid cells and the macrophages. So we sort of have been thinking about it in terms of thinking about it sort of from the end point of tissue damage and thinking about, well, what is it, which tissue damage are we thinking about that our cells might be playing a role in? And that's where we started talking about bone and osteoclasts. So what is the hallmark problem in rheumatoid arthritis is really bone erosion. And it was shown a long time ago by Ellen Gravelis and Steve Goldring, who were really the originators of sort of looking at the immune system and bone in rheumatoid arthritis, and showing that osteoclasts were really the cell that was responsible for rheumatoid arthritis erosion. Now that seems sort of a given at this point in the world, but actually at the time they showed this, it was actually really not clear that osteoclasts, the same cells that erode bone during osteoporosis and during normal bone turnover, were actually the cause of erosion. Some people thought it was a different type of cell. And so there was a lot of controversy about this. So their work was very key in showing that osteoclasts were the cells that were responsible for rheumatoid arthritis erosions. Now, osteoclasts, remember, are sort of a highly differentiated myeloid cell. So they really come from the same myeloid progenitors as macrophages, dendritic cells, neutrophils, and granulocytes. And they really are just a fancy, and when I started working in this field, I sort of thought, oh, osteoclasts are just a fancy macrophage, but that's not the way the bone people would like to think about them. And so they're just a very highly specialized, differentiated cell of their own. So osteoclasts in a lot of ways are still defined by their phenotype more than any specific marker. They're defined by their phenotype, which is being a multinucleated cell, which is created by fusion. The fusion occurs under the stimulus of very specific cytokines, rank ligand, which is the key cytokine for osteoclastogenesis, and MCSF. And rank ligand, as you all know, is the target of denosumab, which blocks osteoclastogenesis, which is why it's used for treatment of osteoporosis. So, but thinking about these myeloid progenitor cells, are there really, we were interested in the question of whether there really were specific myeloid progenitor cells that went to become osteoclasts. Now, osteoclasts are also defined not only by their multinucleation status, but the fact they make a number of bone-degrading products, including matrix metalloproteases, acidification, and they form these pits. The picture on the right is actually a scanning electron micrograph showing the osteoclast on top of these the yellow arrows point out the holes in the bone. So osteoclasts move like over the bone like a little snail, and they actually erode the area right underneath them, and they actually sort of form a seal on top of the bone and exude their bone degrading substances, and then they move over like a little snail. And so you actually will see this little snail track. So we started looking at the question of whether or not there were osteoclast precursors. And sort of when we were thinking about this sort of naively in a lot of ways, we thought, okay, just like in most immune response situations, cells will exit the bone marrow and they will go into circulation, and then they will go to the target organ of action. So we thought, well, we could look in the circulation and see if there's more osteoclast precursors, and maybe use that as a kind of marker, in a sense, to see if patients were more likely to have bone erosion or less likely to have bone erosion. So the idea is that cells would exit from the bone marrow, go into the circulation, and then eventually deposit back in the location where they would become osteoclasts in the rheumatoid pannus, and then under the stimulation of rank ligand, they would form, and a lot of different cytokines, they would form these osteoclasts and erode bone. Because as you know, you don't have osteoclasts in other places in your body. You seem to have them specifically at areas of specific joints, and it's not all joints either. It's very specific sites in each specific disease. All right, so we and a number of other groups has started looking at these cells, looking at cells from the periphery. So we took monocytes out of rheumatoid arthritis patients. So what we did was we took the cells out of the blood, peripheral blood, and then we isolated monocytes specifically using a sort of a beads sorting strategy. And then we differentiated those cells in vitro under the stimulus of rank ligand and MCSF. Now, if you took them out of you or any normal individual, you would get some osteoclasts. But many rheumatoid arthritis patients make a whole lot. So the patient on the left actually makes a whole lot of osteoclasts. And this patient on the right, even though we put in the same number of monocyte type precursors, actually made very few. And they were obviously very different in terms of both they were different in terms of their disease activity, but they were also different in terms of the drugs they were on. And so we were sort of interested in seeing whether or not this could, what were these cells, what was different about them, and whether or not we could identify patients that were more likely to go on to have bone erosion or not. So we were more enthused about this actually initially because we saw that a couple of other investigators had suggested that sometimes therapy could change the ability of these circulating monocytes to become osteoclasts. And we found that to be true as well. So if we took patients before they started on a TNF inhibitor, just on methotrexate, so this one patient is on methotrexate and prednisone, and that patient makes a huge number of osteoclasts on the left. And this same patient, 4 months later, we took the same number of monocyte precursors that phenotypically look the same in terms of like CD14, CD16 kind of markers. And actually, and then now 4 months later on the etanercept, they make far less. So clearly these monocytes are very different in the patient before and after TNF inhibition. And we know that TNF inhibition can both decrease bone resorption at local sites and actually also can decrease bone resorption diffusely. Patients that are on, with rheumatoid arthritis that are on TNF inhibitors can have slight improvement in their diffuse bone density as well. So, so we decided to look at this more closely. We really needed to use a mouse model. So we started looking with the mouse model that we have studied over a number of years is the Skg model of arthritis. So the Skg model of arthritis was developed in Japan by Dr. Sakaguchi, and it's a mouse on a biopsy background that has one point mutation. The point mutation happens to be in ZAP70, which is the signaling molecule that's important in T cell receptor signaling. So the consequence is that this mouse has abnormal T cell development. So they have abnormal T cells. However, the mouse does not get arthritis right away. It's fine. It just has abnormal T cells. However, if you inject it with a sort of innate stimulus, such as Zymazin, that mouse a few weeks later will develop an inflammatory arthritis. They develop an inflammatory arthritis of the sort of paws at both the ankle and the wrist and in the digits as well. And they also tend to develop a little bit of lung disease, and they're CCP positive, rheumatoid factor positive. So people think that there are enough similarities in this mouse model that it is not a perfect but a reasonable model of rheumatoid arthritis inflammatory disease. The other thing that's interesting about this mouse is that after they develop arthritis, you can take their T cells out, give them to a naive mouse, and the T cells can transfer disease. So that's what on the bottom here. If you transfer the CD4 positive T cells to a nude mouse that doesn't have arthritis, they will develop arthritis. So the disease is transferable by T cells. We liked it because it required an innate stimulus to change what was happening in the mouse that had abnormal T cells. All right. So we also like this model because you could follow their arthritis over time. So this is the number of weeks after the innate stimulus. So they start developing more arthritis about 4 weeks after the innate stimulus, and they continue on and continue to have arthritis over the next 12 weeks. And there is a sort of all the female mice, 100% of them get some arthritis. Sometimes it's a little bit variable. Some of them get very mild arthritis, but it is pretty 100% penetrant. And the male mice get arthritis as well, but not as many of them. That is not 100% penetrant. So we've done most of our experiments that I'm going to talk about in female mice because of that. So the last part that we liked about this model was that these mice also have diffuse bone loss and localized bone loss, and they also have increased numbers of osteoclasts. If you take out their peripheral blood or their bone marrow, they will make a large number of osteoclasts. And the SKG-C is the control SKG mouse without the innate stimulus. So the T cell abnormalities alone don't make them very osteopenic or have a lot of osteoclasts in their periphery. But once they get the innate stimulus, 4 weeks later, they have a lot, 4 to 8 weeks later, they have a lot of bone. They interestingly get a lot of bone loss very quickly, and they also make a lot of osteoclasts. So Julie Charles, who was in my group at one point, and started doing these studies to look at whether or not she could isolate really an osteoclast precursor cell. So what she did was take the cells out of the bone marrow, label them with many and all kinds of surface labels, and sort them, looking for specific populations and differentiating them in vitro to be osteoclasts. And she wanted to look at a lot of the known myeloid precursor markers as well as some that were unknown. And what she isolated was a population that was C11b negative to low and Ly6C high in the bone marrow that actually seemed to markedly increase in the arthritic mice. And these cells also went on, in vitro, could very easily become osteoclasts. So they were part the way down the way. She could also isolate these cells. They were increased in other models of arthritis, such as the TNF transgenic had a lot of these cells as well. So there did seem to be an enhancement of this osteoclast precursor population in response to the development of inflammatory arthritis that could easily be isolated, and it was similar to the cells that were circulating around the periphery of human arthritis patients. She went on to show that the markers on these osteoclasts seem to be distinct from a lot of the other known precursor cells. They were different from the common dendritic cell precursor or the myeloid dendritic cell precursor. So we sort of tried to call this distinct myeloid precursor stage. And so we asked the question, okay, if the myeloid precursor number is one of the things that leads to whether or not you're going to have a lot of bone erosion, what's the effect of giving more? So if we increase the number increases in the mice that have inflammatory arthritis, is that really what's driving a lot of the bone loss or the bone erosion? And could we use that number in a way to look at patients? But so we decided to first do it in mice and increase the number in circulation. So we decided to go back, and remember these mice, well, you can adoptively transfer this disease. So we figured this would be a good way to do this. You take the T cells, put them in naive mice, and they would develop arthritis. At the same time, we put different numbers of osteoclast precursor cells and see if they develop different amounts of erosion. That was our plan or our hypothesis. Of course, things don't always work the way you think, but so our initial studies were great. You took the T cells out of the mice that had arthritis, and you put them in the naive mouse that didn't have any T cells, and they got arthritis. And if you are controlled to block that process was to inject the CD4 positive T cells with T regulatory cells. And if you inject the T regulatory cells together, the mice did not get arthritis. Well, what we didn't expect was if we put in the osteoclast precursor cells with the T cells, they would also have decreased arthritis. They were acting more like T regulatory cells. We thought they would have the same amount of arthritis and more erosion. That was our hypothesis, but it didn't turn out that way. And so Julia, to her credit, went on to sort of try to understand exactly why this was occurring. And what she found was that actually the adoptive transfer of the osteoclast precursors decreased the arthritis. So this is on the top, you can see the histology, you see a lot of purple areas, lots of areas of inflammation. And on the bottom, when you put the osteoclast precursors in with the T cells, you really see very little purple inflammation, and you don't have any erosion. So on the left is the erosion score, and on the top is the inflammation score. So there was less inflammation and there was less erosion. So this was completely the sort of opposite of actually what we had expected in a lot of ways. So the osteoclast precursors, increasing the number of them didn't actually cause more erosion. It actually led to decreased arthritis and decreased erosion. So in thinking about it, that basically the osteoclast precursors were acting like T regulatory cells. And there is a population of myeloid cells that's described to be myeloid-derived suppressor cells. In other words, they are like T regulatory cells. They can suppress T cell proliferation. So it seems that the osteoclast precursors are suppressing them. Now, in many other systems, myeloid-derived suppressor cells were mostly described in cancer literature, and these monocytic myeloid suppressor cells did have the same surface phenotype as the osteoclast precursors we had identified, and they suppress T cells by a number of mechanisms, by promoting reactive oxygen species, secreting arginase or nitric oxide. So we tested all of these things, and we did find that yes, if we mix T cells in varying ratios with the T cells, we could suppress T cell proliferation. So this is a T cell proliferation assay. The control is on the left, the black, that's T cell proliferation, and then we add an increasing, a decreasing ratio of osteoclast precursors, and it suppressed T cell proliferation quite significantly. If we added other myeloid cell populations on the right, they didn't suppress T cells. So these osteocells that were particularly prone to become osteoclasts actually were also functioning as monocytic suppressor cells. Julie went on to show that this T cell suppression required interferon gamma and nitric oxide. If by using different inhibitors, she could show that she could reverse the T cell suppression. So it was clear that, and she also showed that rank ligand had no effect. So actually, another group has actually shown that osteoclasts themselves actually can suppress T cell proliferation when the T cells are right on top of the osteoclast. So the T cell osteoclast interaction seems to be bidirectional. The osteoclasts and the osteoclast precursors can both suppress T cell proliferation. The T cells produce the interferon gamma that can block formation of osteoclasts, and they also stimulate the osteoclast precursors. So this T cell osteoclast interaction can be bidirectional. So we sort of think that the reason why, in a lot of ways, the effort to make these enhanced osteoclast precursors is actually an effort at downregulation. It's an effort to try to resolve inflammation, not highly effective, however. It's highly effective in our transfer model because we put the T cells directly in the same tube as the osteoclast precursor, and they go in together. So in that situation, when they're right together, and they actually are very good at suppressing. In the body, where the osteoclast precursors are circulating around, not necessarily right next to the T cells, it doesn't actually happen as effectively as we'd like. But in some ways, we realize that osteoclast precursors are one of the sort of cells at the sort of junction of here, and that they're an effort to try to downregulate and resolve inflammation. But the consequence of them, because they're ineffective at that, is to go on to cause tissue damage. because there's enough other, the stimuli to develop osteoclasts is strong, and they go on to develop tissue damage. So but back to the original question we actually started with was, would the number of these actually predict at all what patients were going to go on to develop more erosion? So we did a small study where we looked at precursor number and the risk of erosions over time. So we basically took all patients, and it didn't matter what drug they were on, in a sense, and looked at them, and they were all on therapy, and then we ended up studying 87 patients. We recruited 115, but 11 of them didn't have all the data, and 17 of them had inaccurate joint counts, we realized, because the person who had done them wasn't really good at doing the DAS score. So we threw out all those. And all the patients were a sort of regular rheumatoid arthritis group. They were all middle-aged female and seropositive, and there were a wide range of ethnicities with mostly Hispanic and white subjects because of the group they were recruited from. So we actually then looked at how these osteoclast precursor counts. And what I mean by this is we took the cells, we isolated the monocytes, we put them in vitro cultures, and then counted the number of osteoclasts that formed. So those assays I showed you before. And then we compared them to see with the group that didn't have radiographic progression and did. And there was a trend a little bit towards the patients that had more osteoclast precursors having more erosion, but this was not statistically significant. But you actually can see a little bit differently on this sort of scatter plot that actually shows the Sharp score on the y-axis and the number of osteoclasts formed on the x-axis. So really, you can see they sort of divide into two different groups. The patients that have very high numbers of osteoclasts actually tended to be on the progressive side, for radiographic progression side. However, it was the patients that had sort of more moderate numbers. I mean, these weren't low, they were a couple hundred still. Lower numbers of osteoclast precursors, they were could be in either category. Some of them progressed and some of them didn't. So we think that it was a little simplistic to just say that that Osteoclast precursor number was going to be the actual predictive thing. I think it probably, in a sense, again, depends on partly their microenvironment. Some of the patients maybe had other factors that were leading to more erosion, or they had different other mechanisms that were also contributing to resolution and not going on to have as much tissue damage. But the patients that had very high numbers of Osteoclast precursors did tend to be in the group that were radiographic progressive. So, but in a sense, you know, so Osteoclast precursors really just sit on this sort of edge of sort of the area of whether or not you're going to develop chronic inflammation that goes on to develop tissue damage or start to resolve. So we were trying to think about other problems that were primarily also mediated by myeloid cells. And the one thing that struck us was that one of the risks that rheumatoid arthritis patients have that is highly significant is the risk for cardiovascular disease and the risk for heart attack. So the risk for patients with rheumatoid arthritis and are at higher risk to develop congestive heart failure and do worse with coronary artery disease, myocardial infarction. And so thus, we all know that cardiovascular disease is a major cause of morbidity and mortality in these patients, and they do have both the increased risk of both infarction and congestive heart failure. And more recently, over the past 5 years or so, there's been increasing information that said that inflammation and immune cells, particularly macrophages, play a significant role in cardiac repair and ventricular remodeling. And so we wanted to know whether or not the changes that were happening in the heart that at all reflected sort of what we see in both the periphery and potentially also in the bone marrow were also related to why potentially, at least in a mouse model, there were differences. So we were surprised to figure out that actually no one had really looked at the cardiac immune cells in inflammatory arthritis mice. It's a little hard to look at those in patients, but even in these mouse models, they hadn't been previously examined. So one of our cardiologists at the VA was very interested in looking at both immune-related therapy for myocardial infarction. And so we decided to collaborate with Dr. Carliner's lab in order to try to understand a little bit more about what was going on in the heart, at least in an inflammatory arthritis model. So we wanted to look at the cardiac macrophages primarily because it really has been the macrophages that have been highly touted as being important in cardiac repair. And this is in normal mice. So there's been a large number of studies, a large group that have been done by Dr. Nerendorf group at Harvard, who's done a lot of this work demonstrating that macrophages really help determine the progression and the resolution of inflammation and repair following myocardial infarction in normal mice. Also, that if you disrupt the macrophage inflammatory response by either depleting them or inhibiting them, you can lead to increased worsening of the left ventricular remodeling. And also there's some evidence that some macrophage or monocyte populations actually can play a beneficial role. So there's been a lot of controversy about whether or not macrophages are beneficial or whether they're harmful. In a sense, they're both, because there probably are different subgroups of macrophages that play each role. Primarily in the initial cardiac studies, they've looked at the two major distinct monocyte subsets, the Ly6C low and Ly6C high subsets that sort of correspond to what people have traditionally called M1 or M2 macrophages, the sort of more inflammatory macrophages like the CD16 intermediate high population in humans, and then the sort of more alternatively activated macrophage or the sort of healing macrophage being the Ly6C low. And that the distinction between how these cells are migrating in and differentiating orchestrates the cardiac recovery. It is not that innate cells are not involved. Actually, there's been a number of studies also that have said that T and B cells can both influence the cardiac repair, and there's also been some evidence that the T and B cells can influence the macrophage response. So this was from their work that showed that there's this biphasic monocyte macrophage response following infarction, in which there's the early influx of pro-inflammatory monocytes into the heart. And now there are resident macrophages in the heart all the time. So the resident macrophages are there to begin with, But in addition to that, there is this influx of very highly inflammatory monocytes at the very beginning in the first day or so after infarction, and then that group decreases, and some of them actually transdifferentiate into the more, quote, healing monocytes. In addition, there's probably some increased influx of those as well. So what happens in the SKG mice? And so we started looking at the sort of, remember the SKG mice are on the BALB/c background. So we looked at BALB/c mice, compared them to SKG mice, and the SKG mice after they had arthritis for 4 weeks. And so clearly, if we just take the heart and we actually digest the heart and basically isolate all the CD45 positive cells and do flow cytometry of a number of markers, we can see that the monocyte macrophage population increases in the SKG mice with arthritis. There's no infarction at all. And actually the more inflammatory subsets, cells that are Ly6C high and MHC class 2 positive, there's already an increased number of them in the SKG mice with arthritis, even though they have normal cardiac function. The SKG mice also have an increased number of neutrophils in the heart at baseline. So they also have increased neutrophils in the heart. They have decreased T cells. They have low numbers of T cells, but these mice that are known to have decreased numbers of T cells in the periphery as well. And there's not much change in the B cell numbers. So the experimental model we did is actually, in order to actually look at cardiac infarction, was we actually do LAD ligation. We have a cardiac surgeon who's worked with the cardiologist for a number of years, who's very skilled at this and actually can do LAD ligation on a mouse, which I could never do, but they ligate the LAD artery, and we've done both. The studies I'm going to talk about are the ones that we did permanent ligation, but you can also do an ischemia reperfusion model as well. And so they ligate the artery, they cause a myocardial infarction, and then we were also interested in looking at effects of immunomodulation. So there's some of the mice were treated after their infarction with an immunomodulatory agent. And then we actually have done a number of studies harvesting these hearts at varying times after the infarction. We assess their cardiac function by echocardiogram, and then we look at their cardiac immune cell populations and by doing digestion and multicolor FACS analysis. So I'll just show you a little bit of this data so that you can see, but actually you'll notice that this is just a representative FACS plot. On the top is really showing neutrophils. So these are negatively gated for a lot of other markers, but C11b and Ly6G positive. And there's a huge numbers of neutrophils go into the heart. This is 2 days after ligation. More in the arthritic mice, a higher number go into the it's a beginning before there's a higher number and higher percentage of neutrophils in the heart before ligation, and then there's more after ligation than the BALB/c mice that have gone through myocardial infarction. And on the bottom are this inflammatory monocyte or macrophage subset, in which they're Ly6C positive, and this is just showing CD11b versus Ly6C, and there's also a huge number of the inflammatory cells. Now there's a large number in the BALB/c mice that have also had ligation, but there's about twice as many in the arthritic mice. So they have more inflammatory macrophages and more neutrophils in the days following ligation. We looked at their cardiac function when they didn't have a heart attack. Basically we wanted to see whether or not just having the arthritis led to decreases in cardiac function, as sometimes does seem to happen in patients. There was a little bit of a trend over a period of 6 weeks. So these mice had arthritis for a total of 10 weeks. So a total of 10 weeks, there was perhaps a little bit of a trend. There's about 8 mice in each of these groups, and we actually we're looking at a longer period of time where there does seem to be a little bit more decrease in the mice with arthritis than the BALB/c mice, but the numbers are not statistically significant at this point because we haven't done enough mice. So we do think that there may be a slight decrease in cardiac function over some time, but it's not tremendous. So without cardiac ischemia, there are increased numbers of inflammatory cells and basically pretty normal cardiac function, which is kind of like most of our patients all the time. However, if something happens, then they have a much more robust inflammatory response. Now, the investigator I was working with had been studying fingolimod, or FTY-720, for a while in its role in cardiac repair. And FTY-720 is a drug that's used for treatment of multiple sclerosis. We don't really tend to use it much in arthritis. It was initially thought it was going to be a transplant medication, but it actually failed in clinical trials. It's a structural analog of sphingosine. And it gets phosphorylated, the drug gets phosphorylated itself, and it actually activates S1P receptors, and is internal, and basically acts as a S1P agonist antagonist. And so this drug has actually been suggested to be helpful in leading to cardiac repair. Now, this drug has been shown to activate sort of signaling pathways in myocardial cells that actually may be important in leading to repair of the myocardial cells themselves. But actually, other groups had not looked so much at its effects on the immune cells. And so fingolimod is known for its ability to change lymphocyte trafficking. And so you don't get influx of T and B cells into the sort of target tissue. They don't exit the lymph nodes appropriately, and they don't enter the tissue appropriately. So it's also been suggested to change macrophage phenotype as well. So the data that our collaborative group had done before we got involved with them was they were looking at these SRB, these scavenger receptor knockout mice that had an ApoE mutation and being fed a high-fat, high-cholesterol diet. And these mice get severe atherosclerosis and actually die very early on after their being on a high-fat diet. And if you give them fingolimod throughout the time they're getting their high-fat diet, they actually survive quite well. And so they actually, it seems to increase the survival of these mice, and so in a very sort of impressive kind of way. And these mice are known to have a lot of inflammation in that they are getting a high-fat, high-cholesterol diet. Their cholesterol is very high, 1,300 milligrams per deciliter, and they get extensive atherosclerosis, and 70% of the cohort dies in a very short period of time. They had also done studies with wild-type C57 mice that were males, and actually shown fractional shortening is a surrogate for ejection fraction in the mouse. And they actually showed that if you treated the mice with FTY after basically they received FTY-720 about 4 hours after their ischemic injury, and they received it for 2 weeks following their ischemic injury. And this is basically at 6 weeks, they had an improvement in their cardiac function over time. So we looked this up in the literature, and it turns out that people had looked at FTY-720 in the literature and Skg mice arthritis, and it actually improves arthritis in this mouse model, though we don't tend to use it in humans. But I should say, I forgot to say that FTY-720 doesn't work equally in all types of mice. So as one of the controls, we actually looked at female BALB/c mice. Remember, all these other studies were done mostly in male mice, and we were looking at female mice that were BALB/c mice because that was the background of our arthritis mice. And what we found was that actually if we took the female mice and gave them coordinate artery ligation and gave them this drug, they did not really improve. So we were sort of, luckily we didn't notice this when we first started because we might have canceled our whole experiment, but we actually continued to do it. And so we did it in the arthritis mice. And these are fairly large groups of mice. They have at least 12 mice in each group. And so we had taken our mice with arthritis. So our Skg mice had about 4 weeks of arthritis at the time they underwent coronary artery ligation, and then they were followed for 6 weeks after that. With their myocardial infarction on the left, they actually had a significant decrease at 2 weeks and 6 weeks of their fractional shortening or ejection fraction. And if we treated them with FTY 720, they actually had significant improvement, very similar to the C57 mice and similar to the SRB ApoE mice, not similar to the wild-type BALB/c females. Now, because these mice's arthritis got significantly better over the course of the 6 weeks, they actually had little arthritis at the end of 6 weeks. We wanted to also use a different drug that we thought would improve their arthritis as well. So we gave them etanercept, which you can give mice etanercept, and a slightly higher dose, but it has been shown to have a significant effect. And we gave them etanercept, and sure enough, their arthritis did improve significantly, but their cardiac function did not. It didn't get a lot worse though, but it didn't get better. And so we thought it was very interesting that one immunomodulatory agent really actually improved both arthritis and recovery after their ischemic event, whereas the other one definitely improved their arthritis, but it actually didn't have a significant effect on the cardiac repair. So what I've shown you really is that the Skg mice at baseline, so these mice with arthritis, have increased neutrophils and increased inflammatory macrophages in the heart. And so in a sense, they're sort of primed to, in a sense, have a more robust sort of inflammatory response with some other insult. And the numbers of cells that both are present in the heart, both probably from some proliferation and some influx, we haven't looked specifically at that, is higher than you would see in the normal wild type mouse. Now, what's interesting is that we gave them this immunomodulatory agent, which had been shown to be useful in several other mouse models, including C57 males and this SRB ApoE model. And it also improved outcomes in the mice with arthritis, but it didn't improve the wild type BALB/c mice. And we can't really tell you absolutely whether this is a male-female thing. Is this a gender difference, or is this a strain difference? Our suspicion is that it's a strain difference, but because we know that C57 mice and BALB/c mice often have opposing T cell responses, but we don't know that. We're actually in the process of trying to look at those two things. And we also know that we also found that etanercept does not improve cardiac outcomes in the mice with arthritis, even though it has significant effects to benefit the arthritis. So we, what I hope to show you is we actually did do single cell RNA-seq on all these mice, and we have seen differences. We haven't, the data is not good enough for me to really show you it just yet. They want us to increase our numbers, but it actually looks like there's changes in both the macrophage phenotype, in addition to the mice that received FTY have way less B cells in their heart, and they have even less T cells, even though so they have decreased both adaptive cells numbers, and they also have a slight change in their macrophage phenotype. And that probably both of those things actually are contributing to their improved outcome. The TNF treated group is the group we haven't actually analyzed, so I can't tell you exactly what that shows. But we feel that actually the alterations in the basal status of the cardiac immune cells is probably responsible for the worsening cardiac outcomes that are happening in both patients and in mice with potentially with inflammatory arthritis. And since treatment actually can seemingly improve both the arthritis, we expect that eventually treatment would actually improve the the cells in the heart itself. So it may be that's why actually cardiac outcomes have improved over time, and now that patients have been on more aggressive, more successful therapy over a longer period of time, maybe they don't have that higher level of inflammatory cells at baseline that's primed to react in the case of an abnormality. our real interest is, in trying to do the single cell RNA-seq data is to really define how the cardiac immune cells are altered with the immunomodulatory agents, because maybe there is actually a better immunomodulatory agent to be on right around a significant ischemic event. Also, there is, and I'm sure you've heard, there's a recent trial in looking at canakinumab therapy in patients that have had repeated MI. So there are potentially new, immunomodulatory agents coming for both cardiac disease, and it may or may not be exactly the same things that are beneficial in the inflammatory arthritis state. And so the better we can define what is actually the best type of treatment that would facilitate cardiac repair is actually probably important to our patients, and in potentially in the personalized medicine aspect of choosing the appropriate drug in rheumatoid arthritis, which we're all still working on. Really, the question is what the exact mechanism of FTY is. Is it really related to the lymphocyte trafficking, or is it really related to its changing the macrophage population, or is it in a sense both? We haven't done the studies to actually put the cells back in with the drug, so we haven't been able to show that specifically. But I think that understanding the mechanism better would actually help us really understand how to modulate the immune system in a sense to facilitate cardiac repair the best. All right, so I'm just going to leave you with that there are a lot of factors that influence macrophage function, and many of them are really the factors that are really present in rheumatoid arthritis. I mean, so if we start at the bottom, cellular metabolism is a key thing. Actually, it's been shown by Connie Williams' group at Stanford that cellular metabolism in peripheral monocytes in patients with both coronary artery disease and without arthritis and rheumatoid arthritis have increased glycolysis. And actually the increased glycolysis is one of the things that leads to more inflammatory macrophages. And so the fact that the myeloid cells have shifted their metabolic profile may be quite significant. Remember also that cells shift their metabolic profile with diet, and maybe that has something to do with also why diet may be important in both response to both in terms of cardiac disease, but also even in response to rheumatoid arthritis therapies. Certainly, there's a lot of microenvironmental changes that happen, both the release of damage-associated molecules, including necrotic cells and hypoxia, and even iron overload. And the resolution factors, a lot of these are things that are made by macrophages or that macrophages can promote, like IL-10 and IGF-1. And one of the thoughts is that one of the ways that macrophages are phenotypically shifting is by changing their IL-10 production, especially in these tissue environments that where they're facilitating repair. So, so these factors are very important and potentially in rheumatoid arthritis, but they're also have impacts on a lot of our other rheumatologic diseases as well as other diseases as well. So I think that thinking about our diseases in terms of chronic inflammation and the factors that can either push you towards more tissue damage or push you towards resolution, I think one of the points made by Dr. Schutz's group is that one of the future therapies, and I think that we will be trying to do more of, in a sense, is trying to promote the resolution process. Factors that can promote the resolution process may be actually even more important than blocking the activation inflammatory side of things, which is sort of what we're doing right now. So trying to think, and potentially even targeting both would be potentially the most beneficial, and also may not be quite as immunosuppressive. If you think about it in terms of actually immunosuppression related to infection. Okay, so finally, I'd just like to thank all the people that actually did a lot of the work. The people on the left, Isabella Imhoff worked with Joel Carliner, who's a cardiologist who got me involved in all this cardiac work, and people in his initial group, Holly Hoover, Lee is our surgeon, and Phil Swigert knows how to do cardiac echoes, which I can't even understand how he does that. I've watched him, and it's pretty amazing to actually, he puts the mice to sleep, and then very carefully has this very tiny transducer, and they get really amazing data that you can actually see and measure People in our group, Christine Shea has helped us a lot with doing a lot of the flow sorting and also the macrophage phenotyping. She's an immunologist who's an expert in myeloid cell subtypes, and Erin Nemi and Matthew Bell helped us. John and Bone and John Graff have gotten the UCSF RA cohort patients, and Julie Baker-LePayne worked with them in terms of looking at those Osteoclast Precursor patients we looked at. And then the studies on the myeloid-derived suppressor cells were really done by Julia Charles, who's now a professor at Harvard, and she did some of her transfer studies in collaboration with Lynn Sue and Art Weiss. And so I couldn't do this without the support of my division and the Russell Engelman Rheumatology Research Center. I should say that the study of cardiac macrophages in inflammatory arthritis mice was funded by the Rheumatology Research Foundation, and I also have some VA funding. So thank you very much, and I'll be happy to answer any questions. Have they done the rheumatoid arthritis model or they've not this particular model, but they have done other models. So in the cardiac model, CCR2 knockouts do a little bit better because they have less influx of inflammatory macrophages. There are other situations though they don't do as well because sometimes those cells are needed. In a sense, actually, in a different inflammatory arthritis model, the serum transfer model, they've shown that actually it's the Ly6C low cells that are actually more detrimental in the synovium that are problematic. Harris Perlman's group looked at that, and so the CCR2 macrophages are not as detrimental. So it kind of depends on two things. One is the model, and it also depends on what location you're looking at. In the heart, the CCR2 positive inflammatory macrophages are not so good, but in other locations, they're actually more important. For example, we did a study of fracture repair and looked at CCR2 deficient mice, and the CCR2 deficient mice actually didn't repair as well. So you seem to need a little bit of inflammation, just not persistent inflammation. You're absolutely right. It should be on there. It should be. You're right. It should be there. I think IL-1 has been thought to be particularly important related to the heart, and the recent IL-1 trial does suggest that in fact it is quite important. And so it is absolutely true that how much IL-1 receptor antagonists the native cells are making may play a significant role in whether or not they're having worse or better repair. Yeah, actually, we wanted to do different studies we were actually in the process of starting to do some different studies using anti-IL-6, and we also wanted to see the effect of the JAK inhibitors as well, because one of the other cytokines that gets upregulated very early on is type 1 interferons with the tissue damage, but we haven't finished those studies, so I can't really tell you what the answer is just yet. These studies kind of take a while because they are a lot of mice, and you can only do a few surgeries every day. But so I don't have that answer, but I agree with you, because actually one of the cells that has been shown to be important in cardiac repair is the amounts of T regulatory cells, and that balance may be shifted somewhat in the presence of anti-IL-6. It does seem to, we didn't see significant changes in the neutrophil numbers, but when we did some what they call RNA flow, which is basically doing, in situ, looking at gene expression with flow cytometry. And we found that the neutrophils were making a little bit less TNF. So it did seem to be changing the phenotype of the neutrophils somewhat, but we didn't see significant changes in the numbers. But we saw less TNF and actually a little less IL-1 as well being produced by the neutrophils by just looking at RNA gene expression. We haven't actually looked at protein in the neutrophils yet.
Going back to joint erosion, how often, when people show these diagrams of osteoclasts getting activated at sites of erosion, they put the stroma and the T cells that are both making red ligand. How often are T cells actually found at the sites of erosion?
Right next to the osteoclast? I don't think very often. I mean, I think that the cells that are really right there are the stromal cells. The T cells, though, may be making a lot of the cytokines that are promoting the stromal cells to make more rank ligand, like IL-17 and well, the T cells, have rank ligand on their cell surface, but I actually don't know that you don't see the T cells right next to the osteoclast very often. I think that's why these myeloid suppressor cells are not very effective in the joint to either prevent T cell proliferation or because they're not in close enough proximity. And I agree with you. I think stromal cells are more important in the driving of the osteoclastogenesis. It's a good question. No, we have not looked at what they do. We have not looked at their stromal cell interactions in the joint. But those certainly macrophages have been shown to be to interact with other fibroblasts quite well, or other mesenchymal cells. No, but we have not looked in our model.
Talking about after the fact of the myocardial infarction, TNF blockers and other immune modulators now is preventing lipid abnormalities to prevent myocardial infarction. What is you're talking about after an MI in humans that perhaps these macrophages altered in repair.
Right, that's what we were looking at. I agree that they were going to have a different effect a priori, potentially even in decreasing the cardiac immune cells present at baseline that may get more activated more easily. So, and also their effects on lipids and endothelial cells are sort of even potentially more so.
I wonder if you, with the impact of the glycoprotein and the functions of the macrophage, like the potential ligand, especially like glycolysis.
Right. We have not done that. Other people have been looking at the effect of different sort of subgroups of lipoproteins and their effects on both macrophage function and their ability to macrophage's ability to phagocytize them and sort of make form cells or not make form cells. But we have not looked at any of that in our model at all. Our model, our mice, to our knowledge, on a regular diet are not hyperlipidemic, but those other mice that the cardiologists were investigating are very hyperlipidemic, and we had actually suggested to them that they look at that because we thought that might be important and why they died so quickly and got such very early atherosclerosis very quickly, but. And I think they are looking at that, but we have not looked at that. Other people have looked at the effect of some of the immunomodulatory agents on lipid profiles, actually in patients, but that's not something we did. Thank you very much for.